Okay, so if you remember, a couple of days ago, we end up the session, the symposium, the Serenovos symposium, with a case in which we were fighting through against a hard clot, and result was not great. And here, I'm going to be presenting a possible solution for these fibrin-rich clots that you can see here. So, well, this nice graphic shows us how we were evolving, progressing in our results over the last years. And yeah, still we are getting better and better technical results. However, there is a substantial part of our patients in which we still are lacking good technique. So this is important. This is core lab assessed trials in which you can see how we can help the patients with the first 3 passes, not bad, about 75–80% rates of complete recanalization. And what happens if we add additional passes, we don't get really much more rate of recanalization by adding more passes. So overall, this is a pooled analysis of all these trials. There is, I would say, roughly, approximately 25% of the patients in which, after 3 passes, we are not achieving an adequate angiographic result. And also we know that the rate of good outcome progressively decreases after the first pass, but also with each additional pass. And obviously, it's better to recanalize, even after 3 passes, than do not recanalize. And the reason, possible reason why, and I like very much this work from Tommy and Albert, in which they explain us why pass after pass it's more and more difficult to retrieve a clot, because we are dehydrating it while we mess with it, while we deploy the stent retriever, and it becomes more and more sticky, and there's an additional friction to the vessel wall, and it's more and more difficult. So this is why the more we try and we are not successful, the less we have the possibility to take out that clot. So also, you've probably seen these presentations of clots according to their composition, and yeah, the theory, and I think is, well, of course, there are very different in composition, and we have tools that work really good for those most softer clots that are rich in red cells. However, we are still probably lacking a good tool for the toughest clots, those who are harder, platelet-rich, and fibrin-rich. So what can we offer them? And this device that you can see here has this geometrical form, which reminds the nimbus, as I'm going to show you later. But it's a geometrical, and despite it might look like a stent retriever, the mechanism of action is completely different. So as I told you, it reminds the nimbus, and this is why it's called the nimbus. But the mechanism of action would be like a whizzer. And I'm going to show you how this can be done. So we are not dragging the clot anymore here. What is meant, the way it's meant to function is like pinching the clot. And here you can see very well how, when you first deploy it and you resheet it, and while you resheet it, this is what happens. You pinch it, and in fact, you're not going to be dragging it like a stent retriever from the whole length of the clot. You're just pinching it, and since it is not friable, it's not meant for friable clots, there's not going to be friability or embolization. You already tried your first pass. This is like a second option, and you nicely can grab it and pull it out. Oops. So if the video is ready, we can play it.
Hello, it's a real pleasure to be with you. Thank you for organizing this symposium. Thank you for Serenovos to have invited me to share our experience with the treatment of tough clots. Here are my disclosures. So what did we learn after several years of experience of thrombectomy? it's interesting to see that our way of thinking has evaluated. And some years ago, we did not expect that we were able to recanalize. And now it completely changed to a situation where failure is not expected. We want the vessels to get open, and we believe that it will mostly work, but unfortunately it does not always work. And the meta-analyses have shown that the rate of failure is still around 30%. And the 30% are the here in the patient that receive a treatment with a poor outcome. That's probably a bit too easy shortcut. When looking at this, in fact, other studies have shown that the more recanalization, the better the outcome. This is not surprising, but definitely you see that in patients with no recanalization, TK0, still some are good, but most are bad. And patients with TK3, the rate of patients with a good outcome is much better. So definitely the goal is to find a way to get the arteries being reopened. So how to proceed? Everybody has his own recipe, and there are not so many ways to do between stent retriever, aspiration, or combination, or dual stent retrievers, what we prefer to do. But now one of the questions which is raised very often is to use rescue stenting, and there are different arguments to do so. And if you look at some of the first results published on this, here is a study published by the EMBOTRAP group with a failure of recanalization which is low, 26 out of 200 thrombectomies, so it's just 10%. And you see out of the 26 patients, occlusion left untreated was a bit more than a half, rescue stenting, but less than a half. And the outcome between both groups was strikingly different. When recanalization was achieved by stenting, those patients were doing better. Same thing from Korean group, where failure recanalization was higher. Now we got 22% or 10%. And occlusion left untreated, 28, rescue stenting, 17. And while comparing the outcome, again, a huge difference where those patients are not perfect. It's not 100% of good result, but still the difference between both groups, whether a stent is placed or not, is strikingly different. And other papers, something that the Hamburg group and our group published, and other colleagues together to look at all the patients now available in different studies, 210, with still 35% of good outcome whenever rescue stenting was done. Interesting also here, this analysis again from Korea, where you see that best situation is when patients have a successful recanalization with 55% of good clinical outcome. Worst situation when occlusion is left untreated, 22% outcome. And rescue stenting is something which is in between, better than if left occluded, but not as good as if efficient thrombectomy is being done, certainly because antiaggregants also may be toxic and produce some hemorrhages. So no doubt, this is still to be proven, but in my opinion, no doubt that efficiency of rescue stenting is something which is interesting, even if the fact to place a stent does not mean that the stent remains patent. And in the end, the patency rate is also something that plays an important role. Rescue stenting, if you consider its patency rate and success rate, is just efficient for half of the patients. So there are alternatives if the clot is not to be taken out, but definitely it seems that it's better to be able to take the clot out. And how to do is something which is not easy, because we try our best, we change from one device to others. And now we're having a growing experience with a device that has been dedicated for the tough clots. Very often the white clots are tough. And here is some of our cases that we've been treating using the Nimbus device. So the Nimbus device has a quite different appearance than the devices that are up to now available, where something which is somehow helicoidal and then the end looking more like a regular stent retriever. And I want to show some pictures of this patient here where we had a stent retriever in place and first one failed, and then second time the stent retriever is again in place, but you see that M2 occlusion still persists. And here it's still occluded. And those are the kind of patients where the more you proceed with your regular devices, the less a chance is there to be able to get it out. And here we used Nimbus as pass 3. And after the single use of Nimbus, the MCA was completely recanalized, as you can see on those pictures. Here are some other examples. Here is proximal M1. So we tried different things. First one, solitaires and combination solitaire and distal aspiration. And then we did another attempt using the same combination again, that again remained unsuccessful. And then we switched to Nimbus and Sophia, and this allowed to take a white clot out and to completely recanalize the vessel. So up to now, we've been using close to 50 devices. And here are, so the efficiency rate is a bit below 50%. And here are the results. Here are some other examples where we have an occluded MCA. And again, first pass does not work. And second pass also fails. Still occluded MCA, and here you see that Nimbus does not always work. It still did not work, so a combination of device may be helpful. Here we took both, but it still did not work. So again, we needed to have a fifth pass, a second combined use of Nimbus and Solitaire, and this enabled to take everything out. So what is the solution? We would be dreaming of one device that enables 100% in all cases. That's definitely not up to now existing. But if we are able to reopen vessels with devices that don't do it, then we increase the chance of having some patients. And here is a recanalization of this patient. Here, another one we probably all experienced treating occlusion of large intracranial vessels in patients having COVID, and those clots are usually more difficult to take out. And here is an example with a basilar tip occlusion. So from the beginning, we wanted to be more aggressive, to increase the chance. That's why we put a solitaire on one side and a Nimbus on the other one. You may see here's a solitaire, here's a Nimbus in the right PCA, and with a single pass, we could reopen it completely. So here are some comments on the way to handle this device. Definitely there is a specific handling and importance of pinching, which is something which is not new, which we've been doing with other stent retrievers. The importance of pinching is very large. We're going to look at this video. I hope I can make it work. And yes, we should see that there is a clot in this flow model. And in the initial phase, we deploy the device, and then to pinch means that you need to bring again the catheter on the device, on the Nimbus, in order to grab and to avoid lose. So the efficiency of the device comes from pinching. Point two, is there an increased risk? Definitely, if you increase the ability to anchor the clot, are we more aggressive to the brain vessels? Presumably, yes. But does it mean that we are too aggressive? Up to now, in our experience, the answer is no. We see that the ability to anchor is higher because when we use this device, we see that the antegrade displacement of the guiding catheter during pulling of the nimbus is increased. We have a guiding which goes more antegradally to the intracranial vessels, but we did not account up to now any complication that was related to this. And finally, it seemed that this is a price to pay to make it efficient. Other comments, how to know what we're treating. Sometimes it's obvious that we treat a clot, but sometimes we treat something and we presume it's a clot, but we don't know. And after one or two passes, you may have an appearance of something looking like a stenosis or a dissection, so that you're prone to rapidly place a stent. But stenting does not always work. Stenting has specific issues because you need antiaggregants and it may induce some bleeding. Look at this patient here. This M2 occlusion where we attempted solitaire, did not work. Here again it's occluded, so we attempt again and it does not work either. But if you look at the arteries, and if you look specific at this segment here where the arrows are, you may see that the vessel looks completely diseased, it's creeping, it's slow, and we may presume that here we are facing maybe a dissection or an underlying stenosis. This could be a dissection, couldn't it be? But we still decided to place numbers. We brought it in, and then when retrieving it, the vessels were completely reopened. And if we look at the zoom here, definitely there was no dissection, but it was a white clot. So the ability to understand is not so easy, and that's why in case of doubt, I think today it's better to make an attempt with another stent reaver, and specifically if you suspect a white clot to be there, to take a nimbus because it may be efficient. So how to determine which is the diseased portion of the vessel? Maybe we need some additional diagnostic tools, and I'm expecting a lot from new technologies, whether it's imaging, whether it's an intravascular device, to help us to recognize which is the pathology we're facing. So is there a role for a more efficient stent reaver? The answer is definitely yes. When to place it? And how many attempts should be placed before? I think that it's too early to give a precise answer to this. It's certainly we're going to have a matter of debate on this. And the number of attempts that can be made, we know that too many attempts is not good. But in our practice, once we failed after twice our regular stent reavers, then we use today the nimbus if we suspect that it's a white clot, in order to be able to reopen the vessels. And in our way to proceed, we don't like so much aspiration. We rather use stent reavers, or a combination of both, or a combination of any device as you like. But before we go on to rescue stenting, using nimbus is something which appears to be of help. And I'm eager to listen to Marc RIBO and to be able to discuss with him on his results. Thank you.
Thank you, René. Just a few more slides with a few concepts, and we can get to the questions and discussion. This nice in vitro study is reinforcing what we've been saying. They analyzed those really tough clots. They simulated them, and they did the experiment of trying to withdraw them either with the solitaire or with the nimbus with 3 passes. And if they could, it was a success. Otherwise, it was a failure. And if failed, the solitaire group could have like a rescue for these even thousand clots with the nimbus. And here are the results. I'm going to express them on the slide, but you see they had 13 clots in each group, and they retrieved the 13 of them with the nimbus, and only 1 of them with classical solitaire tools. And from those 12 that could not be retrieved, after 1 pass of nimbus, 8 could be retrieved. So I mean, this clearly tells us that the nature of the clot clearly influences our outcome, and even more, I would say, why in the upper group, the solitaire group, why they could only achieve 67% rate of recanalization after rescuing with the nimbus? Probably because, as I said, because those clots were already messed up, they were more sticky, they were dehydrated, and more difficult. So ideally, we should be able to identify, as René said, as early as possible, diagnostic tools that will come, the nature of the clot. And this is, just to finish, one of our cases. You should know that there is an ongoing trial study which aims to include the 50 first patients, and is currently has recruited more than 70% of the intended patients. And we're going to have like prospective data about the efficacy and the tougher clots, and where you should deploy. So just a technical note here. So if this is the clot, there is an area where the device works. It has the pinching capability, which is between the 2 markers here, and if it's either too proximal or too distal, it will not work. But this is the concept, and so it works like this. You deploy it as you would do with any stent retriever, as you can see on your left. And instead of pulling at this point, you will resheath until the point that you feel some kind of resistance. And this is something happens when you resheath it up to the mid, or sometimes it's more initial, but then you feel a resistance, so you know that you pinch the clot, you keep pinching with your right hand, and then you pull all the way it out, and you got a nice result in this case. So just to close, so we had good tools for, let's say, the right range of clots, most softer, and probably we are not covering the full range of histological clots. And ideally, as we're saying, we should have some information about the nature of the clot to choose initially the best, to tailor for each patient the best option. So I'll leave it here, and we can have a round of questions if you want. Thank you very much.
Thank you, Marc. Thank you, René. So René is still there in direct, so you can see him now on the screen. And he looks bigger than Marc, but at least Marc is present. This is a big difference. And you escape, I think, from yesterday. Okay, René, okay. So let's go. Questions?
So about the shape, the nimbus shape, what's the sort of the point of it, or what's the basis for the nimbus shape making it more effective? And the second related question is that presumably it's an optimization problem where if you go too aggressive, you'll produce vasospasm dissection, and René mentioned it in his talk. So, I haven't understood, I understand the part about pinching, but I didn't understand the part about the shape of the nimbus.
Okay, maybe it looks, I will answer, René, sorry. But maybe it looks stiffer than it is. It's not so stiff. It just has this geometrical shape, and I guess is to ensure that, or to increase the chances that at some point you will pinch it. So it will be deployed around around the clot, and at some point you will pinch it when you resheath. Want to add something, René?
Yes, the design of the Solitaire, Trevo, and all others is something where you have some struts that close and get together when you take it out. And it's the closure of the struts that probably helps to grab the clot. With the Nimbus, the design is something which is wrapping around. And while you see it also that it shortens what the other don't do. And while because it's wrapping around, the need for pinching is more important, but then the grabbing is more important. And this is to be seen by the fact that the ability for the guiding to be pulled up is more important with Nimbus than with classical centrivers. So I would say the main difference is that grabbing is stronger, so that the sticky clots have higher chances to come out.
So Marc, in order to pinch, you need a microcatheter to be close to the Nimbus. So normally we take the microcatheter out to increase the power of aspiration. So with the Nimbus, we're losing that capability because you are leaving the microcatheter in. Have you seen any disadvantage for that?
Yeah, theoretically it could be. However, I think if you use the largest bore aspiration catheters, like 070 plus, the effect of leaving the microcatheter is not so important as if you use smaller aspiration catheters. But certainly you need so the effect comes because you are pinching between the microcatheter and the device, so you need to keep the microcatheter.
René, one more question regarding the pinching. You nicely showed 2 or 3 cases with kissing technique together, one Nimbus and one classical stent. So I can imagine that increases the stent surface towards the thrombus. Is it also probably more pinching likelihood, successful pinching likelihood, or is it independent effects from kissing stents?
No, probably it's the same. I mean, it's all about being able to grab the clot. And the more there are little hands, little things that catch the clot, the more you increase the chance to get it out. And how many centrivers? I mean, you cannot extend it as much as you want. But in the end, the goal is to get it open, and we're trying to find out a solution. And as I said, it's not, unfortunately, very often not single device that makes it, but probably a cocktail and combination of things.
And René, as we move towards monster vacuum cleaners, do you think this problem will sort of, like, this is a transient problem, and as we go towards monster vacuum cleaners, they won't care about what the clot is made of? They'll just suck out whatever comes on their way. Like the 88s and the 94s. And
they carry also their amount of drawbacks. So not sure that it's not because the catheter is larger that it makes everything. In the end, we still not have a proof that aspiration is better. And from my understanding or my experience, between 2 devices, which is one aspiration and one centriver, if you combine 2 devices, I prefer to combine 2 centrivers and one centriver and one aspiration. So I'm not sure that aspiration is so good.
Okay, thanks a lot. Time is finished. Thanks for both, Marc and René.